Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the Deep Dive. Today we are tackling a profound clinical challenge. Managing major surgery when your primary tool for resuscitation allogeneic blood is just off the table.
It is. It's a scenario that forces us to think differently, to be proactive. This is really about high-quality patient blood management, or PBM, applied with absolute rigor.
Right, and it's framed as a limitation, but it's also an opportunity.
It is. And the key thing to know is it's not an impossible situation. The evidence is actually very clear that with structured multidisciplinary protocols, we can achieve comparable and sometimes even better outcomes.
And that's our mission today. This is for you, the surgeon, the doctor, the intensivist, looking for that structured roadmap. We're diving into published protocols covering everything from the legal side to optimization to the intraoperative techniques for Jehovah's Witness patients.
Before we jump in, we have to state our mandatory clinical reminder. This content is a synthesis of published evidence for reference only. You must always follow your local hospital guidelines, your institutional policies, and national legislation in your own clinical practice.
Always. Okay, so let's start with the foundation, the legal and religious framework. What exactly is the patient refusing?
Okay, so the core refusal is very specific. It's for allogeneic whole blood, red blood cells, white blood cells, plasma, and platelets. That's the absolute line.
But there must be some gray area, right? There's so many products derived from blood.
Exactly, and that's the first critical conversation. Individual patient consultation is key. The acceptance of plasma derivatives, things like albumin, factor concentrates, fibrinogen sealants, that varies hugely from person to person.
So one patient might be fine with recombinant EPO and another won't be.
Precisely. And that choice has to be discussed, clarified, and then formally documented with every single individual before you go anywhere near a procedure.
And that documentation ties directly into the legal strength of their refusal. Patient autonomy is the bedrock here, and UK case law has been incredibly emphatic about this.
Yes, very much so. The law is clear. A capacitous patient, someone who understands the consequences, including death, has the absolute legal right to refuse a blood transfusion.
And that was reaffirmed pretty powerfully recently, wasn't it? Even for minors.
It was. A 2024 UK judgment confirmed that even a capacitous 16-year-old has that right to refuse. The patient's choice, if they have capacity, prevails over the clinician's opinion.
That's a huge weight on the clinical team.
Yeah.
It really underlines why all this advanced planning is so critical. But what about the nightmare scenario? An unconscious patient, no advance directive on file.
Well, in that very specific, immediate, life-threatening emergency, if there's no documented advance decision, the legal framework does give clinicians discretion to transfuse to preserve life. But, the whole point of the selective planning is to prevent that conflict from ever happening.
Okay, before we get to the planning itself, let's talk about a resource you mentioned. The Jehovah's Witness Hospital Liaison Committees, the HLCs. When do you get them involved?
As early as possible. The moment an elective patient presents. The HLCs are a fundamental resource. They're global. These are trained, community-based volunteers.
They're not medical staff, though.
No, but they are trained to understand the clinical strategies and the evidence. They facilitate physician-to-physician contact, they provide packets of peer-reviewed papers, and they just help ensure everyone is making a shared, informed decision. Their involvement can really de-escalate a potential crisis into a manageable plan.
So the legal and documentation side is clear. Let's move to the planning, because success really does seem to hinge on what happens weeks before the scalpel even comes out.
It absolutely does. Once you have the formal consent and the advance decision to refuse filed, the next critical step is aggressive hematological optimization. You have to treat every patient as if they're already anemic.
And this starts with IV iron. We're talking rapid correction here,
Yeah.
right? What's a realistic timeline?
With modern formulations like ferric carboxymaltose, say 500 to 750 milligrams, the kinetics are really quite fast. You can realistically see hemoglobin jump by 1 to 1.5 grams per deciliter in the first week.
Wow.
And if you have a good 6 weeks, you might correct a deficit by up to 3 grams per deciliter. That's a huge buffer before you even start.
That's a game changer compared to oral supplements. But it's not just about pumping in iron, is it?
No, that's a common pitfall. You have to screen for and correct the other things that limit red cell production. So B12, folate, and vitamin C.
Vitamin C.
Yes, often overlooked, about 500 milligrams daily. It significantly boosts non-ham iron absorption, and it supports the efficacy of EPO if you end up using it.
Which brings us to the next step. If the anemia is severe or you just don't have enough time, you move to erythropoiesis-stimulating agents, ESAs, like EPO.
That's right. ESAs basically tell the bone marrow to work overtime, and the evidence is very clear. EPO combined with IV iron is much more effective than iron alone, especially when you know you're facing a guaranteed blood loss from major surgery.
And what's a typical dosing regimen look like?
Well, for an elective case, a common approach is 40,000 IU of EPO subcutaneously, once a week, starting a week or two before surgery. If it's more urgent, you might see a more intensive regimen, maybe 20,000 IU daily for 5 days for a rapid boost.
But again, we come back to patient choice. Not all Jehovah's Witnesses will accept EPO.
That's right. It needs a specific discussion. On average, about 2/3, maybe 66% do accept recombinant EPO. They see it as a stimulus for their own body, not a blood component. But again, it's an individual's conscience. It has to be documented.
Okay, so that's building up the supply. Let's shift to minimizing the loss.
Yeah.
Intraoperative conservation. How does something like cell salvage work here?
It's generally acceptable, but with one absolute non-negotiable rule.
Which is?
The blood must remain in a continuous extracorporeal circuit. It cannot be collected, put in a bag, stored, and then reinfused. That continuous loop is what maintains the theological integrity for the patient.
That's a really subtle but critical technical point. And what about the usual clinical limitations? When would you avoid it?
The standard limits apply, but you're even more careful here. So it's not recommended in cases of active bacterial infection or known malignancy because of the risk of reinfusing bacteria or, theoretically, tumor cells.
And tranexamic acid, TXA.
TXA should just be the default. For any patient at risk of moderate blood loss, say over 500 milliliters, it's 15 milligrams per kilogram IV at induction. It's cheap, it's easy, and it's incredibly effective at reducing blood loss.
And for the really big high-risk cases, what about acute normovolemic hemodilution, AHD?
AHD is reserved for those complex cases where you anticipate a very large loss. You withdraw a unit or two of blood right before surgery starts, and you immediately replace it with crystalloid or colloid to maintain the volume.
So the blood you lose during surgery is more dilute.
Exactly. It has a lower hematocrit. Then, after the high-risk bleeding phase is over, you reinfuse a patient's own fresh, whole blood.
This brings us to the moment of truth, the point in the procedure that requires a total mindset shift. We can't use our standard transfusion trigger of hemoglobin less than 7, so what do we monitor instead?
We have to stop looking at the number and start looking at the physiology. This is the single hardest shift for clinicians. We know that healthy, optimized people can tolerate a hemoglobin as low as 5 grams per deciliter if the drop is gradual. There are even documented cases of survival below 3.
But our surgical patients are rarely perfectly healthy. If they have comorbidities, cardiac disease, sepsis, that safe threshold changes, doesn't it?
It changes dramatically, yes.
Yeah.
The safe threshold goes up probably to around 7 or 8 GDL if there's sepsis, acute trauma, or myocardial ischemia. In those situations, the body's compensatory reserves are just gone.
So if the HB number isn't the trigger, what is? What are the clinical signs that make you intervene?
You're hunting for signs of tissue hypoxia. So hemodynamic stability is the heart rate climbing, is the blood pressure dropping, peripheral perfusion, is urine output falling, and most critically, the metabolic markers, lactate and base deficit. Those are direct measures of cellular oxygen debt, and then, of course, the patient's symptoms. New chest pain, confusion, shortness of breath at rest. Those are the red flags that demand you escalate.
Postoperatively, there's the problem of iatrogenic anemia. The blood we take for tests, it seems small, but it adds up fast.
It adds up devastatingly fast. The single most effective strategy here is a cultural shift to phlebotomy reduction. And that means implementing pediatric blood tubes for all routine investigations.
That's a simple change.
It's a simple change that reduces sample volume by 30 to 40% instantly. It also means using point-of-care testing and just bundling blood draws. It takes active training of the nursing and ICU staff.
And the aggressive support? The iron and EPO that continues post-op?
It continues until you have a solid recovery, usually an HB that's stable above 8 to 10. And the key thing here is a very, very low threshold for escalation. Any sign of instability, you move instantly to radiology, back to theater, or to the ICU because you have zero margin for error.
If we pull all this together, it's really not just about managing a niche religious requirement, is it? This is just the core principles of patient blood management, applied with incredible rigor. The coordination must be enormous.
It's a true testament to multidisciplinary teamwork. You need the surgeons, anesthetists, hematologists, intensivists, pharmacy, and the HLCs all working together. It shows what coordinated care can really achieve.
So what's the bottom line for the clinicians putting in all this intense effort? Does it work? You said the outcomes could even be better. How is that possible? How can avoiding a life-saving therapy lead to a superior result?
And that's the pivotal question. The evidence is robust. Major studies looking at Jehovah's Witnesses in complex cardiac or orthopedic surgery show mortality, long-term survival, and quality of life that is, yes, comparable or statistically better than matched transfused patient groups.
Why, though? What's the mechanism for improvement?
Well, it's because this approach forces systematic optimization from the very beginning. And critically, it eliminates all the known risks of allogeneic transfusion immunosuppression, TRALI, volume overload, even simple administrative errors. By meticulously managing everything weeks ahead of time, we're actually providing a higher quality, less inflammatory, more personalized intervention. It proves that managing low HB is a systematic challenge to be planned for, not an emergency to be fixed with a bag of blood.
That is a powerful conclusion, and it leaves us with a final, provocative thought for you to consider. If these rigorous, systematic bloodless protocols lead to such excellent outcomes, what aspects of this, especially that aggressive pre-op optimization, should become standard practice for all our high-risk surgical patients, regardless of their beliefs?
And as we close, a final reminder for every clinician listening. This content is a synthesis of evidence for reference only. Always, always adhere to your local clinical guidelines and institutional policies in your practice.
If you found this deep dive valuable, please don't forget to share it with at least one colleague or friend. Help spread the word about evidence-based bloodless medicine. And you can also check out our YouTube channel and other social media pages for more. We'll see you next time.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.